Good morning.
Good morning.
So we are going to enter menopause land with our questions. And I think we have some really good ones today, but we always do. So why even say it? Good morning to you, the women, the men, everybody. It's a nice day, and I'm hoping everyone is well. So let us commence with question number one.
All
All
right.
right.
I like this one. I do. Woman writes in, well, they say, as I read, we want our hormone levels to be exactly like they were when we were teenagers, right? And what are those levels anyway?
Yes. We have an echo too.
Oy, oy, oy. Okay. Sorry.
No is the answer. Next question, please. No, I'm just kidding. In order to menstruate, you need a substantial amount of estrogen, enough to form an endometrial lining. And that's a rich amount. And it varies young woman to young woman. Some women, they need this much, which is that, let's just say it's that much. And other women, they need this much. And then there's everything in between. So there is no specific level ever for any human being of anything. There's always a range, and it's called the reference range. And if any woman falls below her personal, let's say she needs this much, if she falls below a certain amount of estrogen, she won't menstruate. You need a certain amount of estrogen to form an endometrial lining and to shed it. And that's not an uncommon thing. I mean, you can have a young woman who is menstruating regularly and then she decides she wants to go to the Olympics, and she starts an Olympics training program, which are very intense and biologically stressful. And our favorite stress hormones, the ones that make it possible to pole vault 32 feet in the air, I don't think that's the actual number, but it sure sounds exciting. In order to get that strong and that fast, to be able to do that, you need a lot of biochemistry going for you. And you need to really jack it up when you're in the Olympics to the fight or flight levels, i.e. from a saber-toothed tiger days. And that recruits a tremendous amount of hormones. At the vanguard, at the head of those hormones, is adrenaline and cortisol. These are coming right out of the adrenal gland. However, every powerful biochemical is recruited, including the powerful biochemicals that come out of the ovary. Thus, estrogens, progesterone, testosterone, and DHEA. Recruited. And an Olympic woman who is an Olympic training athlete who is overtraining, I don't think they call it overtraining. I think they call it the amount of training you need to win. But it's really overtraining for a physical body. She'll recruit all those hormones to get her to have the most power and the most endurance that she could possibly have. And in so doing, not all of her estrogen is going to go down her estrogen pathway. Some of it's going to go down, not all of her estrogen is going to go down her female pathway. Some of it is going to go down her Olympics training pathway. So much so is going to go down that Olympics training pathway that she's going to stop menstruating. She's not going to have enough estrogen to form an endometrial lining. And you look at these Olympic athletes or all kinds of different stressful situations, women are not menstruating. So to dip below that amount that a woman needs it can occur even in a young woman by increased demands. She needs a certain amount to menstruate. Well, that exact same amount that she needs to menstruate does a heck of a lot of other stuff in her body, an amazing amount of other stuff. One thing it does once a month, go figure, it prepares a woman for getting pregnant. Okay, well, one part of that is preparing a woman at that very, very beginning stages to prepare for breast glandular, for breastfeeding. So she gets increase in the breast glandular cells that produce the milk every single cycle. She gets proliferation of breast glandular cells. In order to do that, she gets additional cells. She gets, and in fact, many women feel this. They feel their breasts get fuller as their cycle goes on. Sometimes even tender, full and tender, because she's getting breast glandular cell proliferation, new cells. Oh yeah, well, how do you form new cells? You do something called cell division, mitosis. That's a very vulnerable time in a cell's life, and that's a time when a woman's DNA could be vulnerable to mutation. But a young woman's healthy, and even if she gets mutations, her immune system will pick it up and get rid of the abnormal cells. Once a month, she gets breast glandular cell proliferation. If she does not get pregnant, the whole process terminates, and her breast gets smaller. The cells that were formed disappear by a wonderful term that's been named apoptosis. These new cells disappear. Again, her breasts get less full, and she starts all over again. Well, in menopause, there is not enough estrogen to menstruate. In fact, the periods stop, and that's one of the hallmarks of menopause. The periods get irregular, and then they stop entirely, and they never come back. Oh, they may sputter along for the last year of menstruation. You get a period, you haven't had one for 6 months. Oops, I got another period. You know, this kind of stuff can happen in that intermediate zone called the perimenopause. But the ovaries stop producing these robust levels of hormones. And then we replenish the hormones. Oh yeah. Do I recommend replenishing hormones in women and men? Oh yes, I do. For 1,000 reasons that you can read in our book, Happy Healthy Hormones. Because you're going to want to feel as good as your life's going to matter to you as much when you're in your 90s as it does right now. And if you don't have those hormones, most women lose so many functions, I don't even want to enumerate them right now. Then the question is, how much do we replenish them? Do we take you back to youthful levels? Well, for most women, we don't. For one thing, very critical functions are achieved without having to bring them back to youthful levels. Your highest levels are when you're 20 years old, plus or minus 2 years. We don't need to bring them back to those levels to, for example, protect the bones and prevent bone loss. A very critical function of these ovarian hormones. Don't lose bones. Not good. We bring the androgen levels back to levels that you don't lose muscle. We bring the estrogen levels back to levels that you don't lose your vagina. Now, you don't actually lose your vagina, but you can get fibrosis of the vagina, you can get vaginal atrophy, that can irritate the urethral meatus, you can get incontinent of urine, and when you couple that with loss of the muscle that holds up the bladder and the uterus, it's a recipe for adult diapers. Well, we know what it takes to replenish enough so that you don't lose those functions, along with several others. And it doesn't take the levels that it did when you were 20, which I find very convenient. If this is the amount of estrogen a woman needs at the low end, she still menstruates, she's still healthy, or some women need this amount. It turns out that the levels of estrogen needed to protect the vagina and the bones, those are two very, very important parameters to assess, is right below the amount it takes to menstruate. This is the range. This is what we treat most, but not all, menopausal women with. We replenish to the levels that fall just shy of what they had when they were young, in most cases. Because if we go higher, we put a woman's breast glandular cells at the risk of proliferation. Well, that's not necessarily a bad thing, but when you're trying to get it as good as you can and keep the risk to the absolute minimal, we think getting breast glandular cell mitosis, cell division, exposure to the DNA, the genes, we don't think that's a good idea. And it ain't just me. I mean, there's a wonderful study that we actually cite in the book from I believe this doctor is from Harvard or Princeton, wrote a very important article, I thought, about he thought it was not wise to put a woman in her midlife at cell division and breast glandular cell proliferation. So we fall just shy of that. And still, you can have libido, you can have cognition, you can protect your coronary arteries, you can protect your bones, you can protect your vagina with levels that aren't youthful. They're just shy of youthful. Are there exceptions? Yes, indeedy. You'd love to make these tremendously profound rules in medicine, only good luck, because there's always exceptions. There's some women who need a robust amount of estrogen to restore their cognitive function, their ability to think. And they need youthful levels. And we start these women who have cognitive challenge / on their way to dementia / dementia. We start them low and we gradually increase those estrogens, and we keep increasing those estrogens until if we're fortunate enough to get their full mental function back. And sometimes we got to go so high with that the period restores. So in that instance, in that exception, I think it's a wonderful thing to do. And don't ask me. Talk to the women who get their brain back. Whoa, so profound. I've given the example of a doctor that I met who did this. I'm not going to repeat it now. But for most women, you don't need youthful levels. If this is youthful levels, we replenish ovarian hormones to just shy of youthful levels, so you don't get breast glandular cell proliferation and thus mutation possibilities. And we make exceptions if we need to, and they're all around cognition. And we just keep jacking that estrogen up until to see if we can clear a woman's brain. There's a lot more possible causes of dementia and Alzheimer's, although low estrogen in women is so common. So you always want to do that experiment first. But I can't guarantee you're going to get your cognition back even if your period comes back, because there are other possibilities that can cause the cognitive challenge and loss. So that's the general thing. We know the numbers. When you do 24-hour urine hormone tests, one of the things I did is I went into the medical literature and correlated how much it took to preserve the bones and the vagina, because the studies have been done to define that. And we even, the laboratory we work with, we even established those parameters. So on every woman's test, we see the amount that they actually have, that is the safe amount. So we use numbers, we use testing. We don't test our women until they're 2 to 3 months, 2 to 5 months into their program, to where we're dialing in their optimal clinical symptom relief and feel good levels. And then when a woman says, I feel good, that's when we test you, and we can see your levels, and we can see the actual numbers, whether you do have enough to protect your bones and vagina. And there's many women, this is maybe the most important thing I'm going to say, they've been put on hormone therapy and they get their hot flashes alleviated and they feel better. Well, our group did a study of these women, and all of these women in this study said, I feel good. And we did a 24-hour urine on them when they felt good. And 50% of those women who felt good, thought they were on adequate dosages, did not have sufficient estrogen to protect their vagina and bones. So it's not enough to just alleviate symptoms, because it's a common practice out there. Well, how much does a woman need? Well, give her enough to alleviate her hot flashes and have her feel good. Well, that's great. I agree. That's a great thing. But you have to confirm that with 24-hour urine hormone tests and compare it to the levels that I extrapolated from the medical literature. There's other ways to assess that. And sometimes, well, 25% of the women that we studied, and these were 54 women that we studied, 25% of the time, they felt good. And they were on levels of estrogen that put their breast glandular cells have a possibility of getting proliferation, thus cell division. It didn't mean we dialed them down. Sometimes they need that amount. But what's the deal? What we do is we monitor the breasts, amongst many other things. We have periodic mammograms. I'm not saying the number of years apart from the mammograms. It all depends on the woman. But when there's increased risk, we monitor the breast more frequently with mammograms, and not as a breast cancer screening tool. We'll monitor with thermograms as well. We never use thermograms as a breast cancer screening tool, never. But they have other value. They definitely tell us about inflammation. So a woman who's getting breast glandular cell proliferation in the menopause, no big deal. We just monitor her breasts. Because cancer has a zillion causes, and it ain't hormones. And it doesn't mean that overdose of hormones can't lead to issues. They can, but they don't cause cancer. Things cause cancer. Oh, yeah. I'm not going to go into that today. There's 1,000 million things that hurt our health, hurt our immune system, hurt our bodies, hurt our cells, put our cells in jeopardy. Oh, yeah, there's 1,000 things that do that. And especially in this day and age, we're exposed to so much toxicity, for example. But I know somewhere in there I answered the questioner's question. What's the right amount? Here's a number for you. You want a number on 24-hour urine hormone tests. The right amount of estrogen, when you add up the potent estrogens, which is estradiol and estrone, should be no less than 8 micrograms per 24 hours and no more than 14 micrograms per 24 hours. And there are exceptions to the upper end, not to the lower end. We want you to have at least 8 micrograms. That number is not going to be very helpful for you. But finding a provider who knows how to do 24-hour urine hormone tests, that will be helpful for you. So that's the amount. You get enough estrogen to alleviate symptoms. We definitely want to, like, for example, if you're having hot flashes in the middle of the night, we want to keep on increasing that estrogen until you do not have hot flashes in the middle of the night. If you have vaginal dryness and pain on intercourse, we want to keep proper estrogen levels going until you do not have pain on intercourse. So there are some very important parameters. So there's clinical parameters, and we use that to dial in what's an optimal amount for you. So when you're taking hormones, there's only one acceptable thing, and it's called I feel good. And there's no acceptable thing about I have side effects or other effects. No, it's unacceptable. Something's wrong in the dosages. But once you feel good clinically because you found your optimal doses of estrogens, progesterone, testosterone, and DHEA, not to mention thyroid, and then we do the 24-hour urine test. And I want to answer this test by Ginny. Is it normal to stop taking your hormones 48 hours before urine test? No, the answer is absolutely not. We want to get a real-time reading of how much is in your body while you're taking the hormones. So the criteria we suggest is that a woman who's doing the 24-hour urine hormone test be religious and exact about her dosages for a week prior to the test. And then to be sure you're taking your hormones during the test. That's how we get the accurate read of what's actually going on in your body from the hormones you're taking. Now, there is an exception in the menopause method or the Bright method. We don't do this exception. The laboratories will often say if a woman is taking oral hormones, well, you shouldn't be taking oral estrogen. So just forget about that. And you can't take oral testosterone. So forget about it. But you can take oral progesterone and oral DHEA. The laboratories will print out in their instructions, omit the progesterone or the oral progesterone and even the oral DHEA the night before you begin your morning collection and the night of the 24 hours that you're collecting. They'll say to do that. There's reasons why they say this. Because they're aware that when you take a steroid hormone orally, 80 to 90% of it is going to go directly to all of it's going to go directly to the liver if you take it orally. And then 80 to 90% of it in the liver right away is going to be biochemically transformed into metabolites. And never make it to the actual hormone will never make it to your body. 10% of it will, maybe even 20% will. So these laboratories believe, you're still getting a rough estimate there, that you're better off getting an idea of what your progesterone levels are. For example, if you omit the progesterone the night before and the night of. Therefore, you eliminate to a certain extent what's called the first pass effect. I don't like to do that. I want our providers to see the very high levels of pregnenolone that happens when you're actually taking oral progesterone, and none of it's a big deal. We don't need such careful assessment of progesterone. So, no matter how your provider suggests, some will suggest, as the labs do, to omit the progesterone 24 hours, the night before and the night of. Not 48 hours. No. Just the night before. Well, I guess that almost does amount to 48 hours with progesterone. Yes, it does. 60 hours it amounts to. But do not omit your estrogen or your androgens, testosterone and DHEA. No. It's worthless. It makes the test absolutely worthless if you omit your estrogens and your androgens, testosterone and DHEA, while you're collecting your urine. So don't omit estrogens and androgens. You can omit progesterone as the lab directs. We don't in our method. We want people to see the high metabolite levels because that's what's actually happening. The DHEA doesn't matter so much. You could even take your DHEA right on through the collection. If you're taking it orally, we give it topically to women. But you could take your DHEA because it has such a short half-life. It means it doesn't stay around in the body really quickly, whereas progesterone does. So yes, if you're going to omit something the night before and the morning of, that will amount to about a 36-hour omission. But if you're going to omit progesterone, only omit it the night before. You're going to begin your collection of urine in the morning. So if you're going to omit progesterone, only omit it the night before. That's when you should be taking your progesterone. And the night of you're collecting your urine. Only that. Don't go 48 hours.
She asked, should I refuse this order? And she also says, my natural doctor said that this is what the pathologist said to do. She says, this is the first time I've been asked to do this. So in the world of menopause, it can get a little confusing,
Well, it can. And the primary reason is, unlike orthopedic surgery or neurology or internal medicine or kidney specialties, nephrologists, urologists, there is no specialty called menopause and andropause.
Well, it's coming.
And there's, yes, hopefully. And there's reasons why there's not, because everybody got scared away from hormones in 2002 with the Women's Health Initiative. So it's in a very primitive phase, and there's very few specialists. I actually am the only specialist I've ever met, and I know a lot of doctors.
And you're you.
And when you don't specialize, you don't have the time, and you don't know what you don't know. So you meet up with this 24-hour urine hormone test, which is it's a piece of work to really interpret it because there's so many analytes. It's wonderful. I'm here today because of it. That's how I got to learn about what was going on in women's bodies. It was just phenomenal. We love it. But it took me, I had to review 50 cases with laboratory advisors before I started getting a handle on it. So don't be surprised when, I mean, the great news is that your provider is asking you to do a 24-hour urine hormone test. That's the great news. Don't fault them for not knowing how to do it. The pathologists don't know how to do it. They know how to do tremendous number of laboratory tests. They're experts at it, but they don't know how to do 24-hour urines for hormones. And as far as I know, the major laboratories that have pathologists, they're not doing 24-hour urines for hormones. There's 24-hour urine hormone laboratories. So forget about what they're saying and just listen to what I'm saying. I'm telling you. And then you'll get results that will be interpretable. Take your estrogens and your testosterone religiously the week before and also during the collection of the urine.
Right, because then you can see
exactly what's going on in your body. And don't omit them. We in our method, we don't want a woman to omit anything. And it makes the directions less confusing. Yes. But if you're going to follow the instructions of the laboratory, omit progesterone only the night before, not 2 nights before, only the night before and the night of, because you only should be taking your progesterone at night.
Okay. On that note, let me ask you this, because it ties in. A woman who writes in often says, I just realized that I never confirmed what the ingredients are in the Menopause Method program. Is it organic olive oil? Is this an appropriate question even for me to ask?
Well, of course it's an appropriate question. If you're putting something into or onto your body, you now have the right to ask. You got the right for an answer. And an accurate one at that. You sure do.
Aww.
In the Menopause Method, and it's now we're getting a name change here to Bright.
Oh, I like the R too. That's really clever.
And we dispense, well, we don't dispense them. We provide everything a compounding pharmacist needs except the hormones. So we provide the bottles and the oils. And we have a patent on this. With 3 patents on this. And what goes into the bottles is the highest percentage is the oils called the carrier. That's what these steroid hormones are carried in. And the pharmacist adds the powder to the bottle of oil. And then in our method, you have to rotate the bottle because there's no solvents in there. So it doesn't go in a solution. It's just a suspension. And it works great. And here's what's in ours. We have a special proprietary blend of 3 oils: jojoba oil, borage, and evening primrose. And it is violation of patent for any pharmacy to put it up in any oils whatsoever. Olive oil, you could put it up in olive oil. It's got an odor to it. It can go rancid. The oils we chose, in the proportions we chose, they don't go rancid. So that's the ingredients in the Menopause Method oils, and there's you can get these, and you can contact Sherry at menopausemethod.com. It's SHEREE at menopausemethod.com to find a provider that you
Yes.
have in your state to dispense this. There's plenty of pharmacies that dispense hormones in our organic oils. There's 31 of them.
Right. So then in those oils, those three oils, you're not going to find peanut oil or acetyl alcohol or red dyes or whatever it is that oftentimes can accompany the hormones that we are given.
Propylene glycol, all kinds of chemicals.
Propylene glycol, yeah, for sure.
No, nothing. There's only 3 or certified organic oils. That's all that's in that bottle, along with the bioidentical hormones.
Right.
And
Absolutely.
pharmacists, and we think that's very important. We think our exposure to toxicity and strong solvents is not okay.
I completely agree. The game changer for me. I mean, I just like zoomed right in. I was like, that sounds good. And guess what? It was and is.
Wasn't is.
Wasn't is.
Wasn't is.
Well, wasn't is and isn't was.
Sounds fun.
It is fun.
Wasn't
and this is fun. So, because you're amazing. So, taking the right type of estrogen, questioner asks, can really help improve low mood and other symptoms. But how does one know what type of estrogen is right for you?
Well, here's your primary job. And I'm going to give you what's not going to sound like a direct answer to your question, but it is the direct answer to your question. Your job is to find a licensed healthcare provider that can prescribe hormones. That's going to be a doctor or a nurse practitioner or a PA, physician's assistant. And in some few states, compounding pharmacists can even do this. Mexico, compounding pharmacists can do this. That's your job, because when you find the right one, they're going to know the right estrogens to give you, because they have done the heavy lifting, hopefully, to learn what's right, what's not right, what's the best. Now, having said that, I suggest that you download our book, Happy Healthy Hormones, because we do describe what is the best. There is a best. And my God, truth be told, from my perspective, a woman who can get any estrogens, testosterone, progesterone, and DHEA is way ahead of the game, no matter what it is, including Premarin or Prempro, derived from horse urine. I'm not saying that derogatorily, because the women who were on Premarin and Prempro, and there were 18 million of them in 2002, 40% of American women were on horse urine-derived estrogens. And you know what? These women did better than women who were not being treated with hormones. And these women who were on Premarin and Prempro were at less risk for breast cancer, heart attack, and stroke than the women who were not being treated. That was the actual science, as the study committee admitted years after they published their false conclusions. So any hormones, if that are available, that are actually in common use, they're all good. They all work. Now, what's the best? By far, I've never prescribed Premarin and Prempro, but I don't fault women who are on them, and I don't fault prescribers who prescribe them. These women are going to do better. It's fantastic, and be at less risk. But the very best is bioidentical hormones. What does that mean? It means the molecule of the estrogens, testosterone, progesterone, or DHEA that you are taking are molecularly identical to what your ovaries produced. Same molecule. Premarin doesn't have this. It's got 50% of the molecules estrogens that are in Premarin were found in a woman's body, but 50% were not. 50% were only found in horses. Duh. Not Doesn't seem like the very best way to go.
The cocking of the head.
But since the evolution of the birth control pill, we've had molecularly identical hormones available to us. And Dr. Jonathan Wright, great pioneer, amazing human being, holistic medical doctor, and Jim Hernser, these are the ones I know who simultaneously in the early 80s said, we know that there's pure estrogen out there. I wonder if we can get it for our compounding pharmacists. And Jim is a compounding pharmacist, and he knew he could get pure estradiol, and he did. Bioidentical estradiol.
Yeah.
And Jonathan talked to his pharmacist and said, look, they've been producing pure estradiol for the birth control pill, even though they change it. They're getting it from soy and from yams. Why can't we get some of that stuff produced by pharmaceutical manufacturers? And sure enough, his compounding pharmacist found it. And that was the early 1980s, the birth of treating women in menopause with compounded, molecularly identical, bioidentical estrogen, testosterone, DHEA, and progesterone. Hallelujah.
Oh, yes.
Now, what is the right estrogens? And that was the question. This is really important. The human ovary produces 3 different estrogens that are metabolically active, or biologically active: estrone, estradiol, and estriol. Estradiol is the most potent of the estrogens that are coming out of the ovary. That was the one that was chosen for the birth control pill, along with the progestin.
Mm-hmm.
In fact, there are doctors who are treating women with estradiol alone. It's estradiol that's in the patches. There's estradiol and pharmaceutical gels. Those pharmaceutical gels and patches came along many, many years after Jim Hernser and Dr. Jonathan Wright launched compounded bioidentical hormones for the women of the world.
Smart.
The pharmaceutical manufacturers lost so much market share to the compounding bioidenticals that they got on the stick and started developing the forms that they could, and they chose pure estradiol. Now, you talk to the most knowledgeable, experienced physicians and nurse practitioners who've been treating women in menopause, they're going to find their way to a different estrogen formulation. And we describe this in the book, and we describe the reasons for this in the book. They're going to be prescribing biased, and these are the folks you want to find. It's one of those questions you can ask the office manager as you're going shopping for the proper provider. What form of estrogen does your provider prescribe? And here's the answer that you want: biased, topical biased. That means you apply it to your skin. That's the only answer you want. If they say biased, that physician or nurse practitioner has done some studying. The bias that we begin with, and we don't necessarily stay with it, but the bias we begin with has 80% estriol in it, 20% estradiol. There's reasons for that, and we go into that in the book. So the proper estrogen for you to be receiving is topical. That means you apply it to your skin. Some apply it to the mucous membranes. I'm not a fan of this, but I understand why they do. But you topical biased. That's the estrogen that you want. Did I answer that question, Carolyn? Did I finally get to the actual answer?
I think. No, I'm just kidding. Yes, you did. Indeed, you did. You did. And I want to acknowledge Antoinette here, because she says, and it's along these lines, is it symptomatically noticeable when transitioning from cream or mucoid-based bioidenticals to Dr. Rosensweet's essential oil brand per reports from women who made the transition?
Well, I don't know what mucoid is. She might be talking about troches, and they get absorbed through the mucous membrane under the tongue, some of them. But there's only one acceptable thing from a transition. There's only one acceptable outcome. And hi, Antoinette. And the outcome is you feel good or better. That's all.
Right.
And sometimes there's a dosage difference mathematically, but it doesn't matter. It's the transitions are very easy to make.
So we need not be terrified.
Not only that, there's no concern whatsoever if she's on bioidentical creams or gels. I used to treat with bioidentical creams and gels until we invented the oils. But there's no big deal at all. The creams, the gels, and the oils, these are called carriers.
Mm-hmm.
You can't just sprinkle hormones on your skin and rub it in, because the form that they come in are powders. So if you rub them on your skin, you're gonna look at some powder on your skin. What the heck happened here? I got a powder on my skin. You've got to put them in something, and what they're put in is called carriers. And the creams and gels are strong solvents. And that means that those powders are going to dissolve in those strong solvents, because the powders themselves are very poorly soluble. We put them in water, they do not dissolve at all. You need strong solvents to get them to dissolve. And that's important if you're using dosage administration forms, like you use a little spoon to dip into the cream or gel, or you do a toppy click, you do a little click, and out comes. They have to be in solution so that the same dose comes out. However, we don't do that. We have them in oils, and before you do each application, you rotate the bottle, you get a suspension, you drip it on your skin. It works beautifully, as mine did for me this morning when I put on my testosterone.
We probably did it at the same time, because I was putting mine on too this morning.
So the one thing for sure is there's only one acceptable thing from a transition, as you feel as good or better. And in order to do that, you've got to get the dosages right, but it's not a big deal.
Well, I agree. Especially when you're working with somebody who is passionate and knowledgeable and enjoys working with women in menopause and men in andropause. And it can be done. Gratefully so, I must say. So, there you go, Antoinette. I hope we answered your question, or that Dr. R did. I didn't answer anything. Please let me go to this question. Lovely woman writes in, I went for 6 months without a period. During this time, I was taking small amounts of estrogen, responding very well to it, and it even calmed my anxiety. I was able to work up to 2.5 milligrams of topical Biest and also add in progesterone. But then, out of the blue, I got my period. Since then, I cannot tolerate estrogen at all. So I guess at some point, I'm probably going to get my period back again, right? I am confused, I am frustrated, and I will gratefully receive any tips or advice. I thought I was done with peri, and now I am all over the place, and hormones are making everything worse.
Perimenopause.
Yeah.
There's this space called being a young woman from adolescence to a certain age. You get best case scenario, you get regular periods, hopefully symptom minimal or symptom free. And then there's this other time of life. Let's see, I'm trying to get it on the screen.
I know, it's weird.
Here's the young life. And here's the menopause. There we go. Different time of life. The ovaries are no longer putting out hormones. No menstruation, zero menstruation. Then there's this place in between called the perimenopause. And like I've always said, your highest level of hormones are when you're 20, plus or minus a couple years, gradually decline. So there's changes even before the perimenopause. And then there's the ovary shut off, and there's no hormones coming out of the ovaries. Bam, none. And you continue to decline. That perimenopause, that space in between, is an erratic time. And a story like this questionnaire that you just read, Carolyn, this is a common story. Like, what in the heck is going on here? I didn't have a period for 6 months, and then I started hormones, then I got a period. You may have gotten a period even if you didn't do hormones. It's a very erratic time. One of the causes for the erraticness is while you're getting this decline, your brain and hypothalamus and your pituitary is watching this decline. And to put it metaphorically, I don't think this is the story your brain is telling itself, but to put it metaphorically, it, quote, doesn't like the decline, and it tries to remedy the decline. And it can do so. It can put out these stimulating hormones from the pituitary gland that it always puts out every month, but it can put out some extra ones. It can give you a little blast of follicle stimulating hormone and luteinizing stimulating hormone to urge the ovaries to keep going. Don't decline. I'm going to give you a bigger blast of stimulating hormone. And that's what's occurring in the perimenopause. Your body is recognizing the decline. The pituitary gland goes, oh, no. We're going to give you a bunch of stuff to try and get that to revive. It's been called many things. The ovary is called the sputtering ovary in that it's erratic. It's putting out these erratic amounts, which can be very disruptive to a day-to-day life. And we suggest that women start hormones as early as they can, because if we can replenish estrogens to a decent level, the erraticness stops. Your general estrogen level is dropped, we replenish, the erratic sputtering thing drops. It will not stop the end of your ovarian production. The dosages we're using are not going to prevent menopause. No way. But they can stabilize you and keep that erratic thing out of there.
Yeah.
But here's what I'd like to say to the questioner. It's okay. There's no illness involved.
Yeah.
There's very, very, very rarely a bleed from the uterus is coming from endometrial cancer. And in 28 years, I've had 2 cases of endometrial cancer, but this is not the usual story. Waiting 6 months. The usual story is I've been 3 years without a period and I started bleeding. And it wasn't accountable by the dosages that the woman's receiving. That woman goes to their gynecologist. That bleed could be a signal of uterine cancer. And it's very rare. Like I say, 2 cases out of thousands of women that I've treated, 2 cases of endometrial cancer. You catch them early, totally curable. Totally curable.
That's the good news for sure. Yeah.
But the kind that's happening within the first year, like, hey, my period stopped, and then 6 months later, it came back. That's usually due to the erraticness of perimenopause. And especially what happened is your period stopped, you went on hormones, it replenished a certain amount of estrogen. It puts you back in the borderline of are you going to form an endometrial lining or not, and maybe you're on a little bit of an overdose. Or it's hard to call it an overdose. You got you got replenished hormones to the level that you got some endometrial lining. This is not bad. There is always the choice by your healthcare provider that they need to make. That does this bleeding sound like I want to send this woman to the gynecologist to get a transvaginal ultrasound? That's what they'll do. Or does it not? Does it sound like this typical perimenopausal bleeding that once we get her stabilized, she's going to be fine? That's a clinical call that a professional needs to make. It's an important call. When in doubt, we refer to a gynecologist. The method that we teach all of our providers is when in doubt, you refer that woman to a gynecologist. It's such a non-invasive procedure to do a transvaginal ultrasound. Yeah, who wants to go to your doctor and have a probe placed in your vagina to do an ultrasound? I mean, I can think of, I think many women have thought, gee, there'd be a more fun way to spend my day. But, these techniques, which is very relatively non-invasive and certainly not harmful, they're a gift from heaven above. They just do a spectacular job. And your gynecologist does this day in and day out, and they know how to interpret that thing. So what we train our providers, if there's some bleeding going on that isn't obvious cause, refer immediately to the gynecologist. And they'll give us the clear answer. So, because cancers are identifiable, they can tell whether that bleeding came from, oh yeah, you're on a little bit of a robust dose. You had a very uniform endometrial stripe of 7 millimeters. It's okay, you're fine. Or the gynecologist in rare instances will say, well, there's an irregularity in there on transvaginal ultrasound. Just to protect you, we want to do a biopsy. They'll do it in the office. And when they say they want to do that, your answer is yes.
Yeah.
Do you want to do that? No. Who in the heck wants a biopsy? But I've undergone procedures that I didn't want to do, but they were extremely helpful.
Me too.
The gift of modern medicine. So when your gynecologist says, I want to do a biopsy, your answer, there's only one answer you want to give.
Okay.
Yes, that's right. Okay.
I'm in.
Yeah, I'm in. That's those variations. Okay, or I'm in, or yes, of course, doctor. That's why I'm here. Yeah, please. All those answers. Any one of those will suffice.
Those will work.
Those will work. And nothing else will work.
No.
The answer is, well, I want to think about that. No, that's not an answer that you give your gynecologist.
Right. Give me 1 minute. I'll think about it. Okay.
That's right.
Side note, I will admit, I had a colonoscopy the other day. Now, this was not very fun at all. However, I was very cognizant, especially in speaking with you as often as I do. I don't even think I talked to the doctor, but this is what he does over and over and over and over. It's his deal. It's what he does. It's what he likes, and that's what he does. And it was really interesting just to watch, the people going in, the people coming out. Yeah. No one was saying no, not the funnest thing I can recommend to anybody.
But there should be no colon cancer, because those who get colonoscopies, they'll pick these gastroenterologists will pick it up at a very tiny, very manageable. They'll just take it right out during your colonoscopy. You're asleep. You're not feeling this. There should be no one dying of colon cancer these days. We got this miracle called gastroenterologists who do a colonoscopy and they know what they're doing.
Yeah, they do. Boy,
and they remove these polyps. They remove these precancerous lesions, and you wake up and you didn't even know it happened.
Craziest thing, yeah.
So anyway, let's go back. I want to go back to this perimenopause. It's an erratic period. This is the other thing I want to mention, Carolyn. It can be emotionally erratic too.
Oh,
yeah. And you could have sleep disturbance. You could have all kinds of feelings that you didn't have. And I'm going to even go a little over today to answer this final question because this
Thank
is so
you.
important.
Thank you.
There's a couple of ways to interpret the erraticness and the disruptiveness of the perimenopause. One way is to say it's bad and wrong, and this should not be happening to you, and you're bad and wrong for having it happen. That's one possible way.
Ooh, ow!
Or a woman could say there's something wrong and bad going on. And that's one possible answer, and that's the wrong answer. One of the things I've learned as a physician for myself and for all my patients is respect exactly what's going on. Start there. And like, there are cultures on this planet, they're historical, they're not now that I know of, where when women would go into their period, the tribe would have a special house and grounds for the women who are menstruating. And what the tribe would do is they would take care of all the woman's duties for her. So she was relieved of all responsibilities. Didn't have to feed the kids, didn't have to prepare the meals, didn't have to walk out in the fields. She could just rest. And because it was a period of special sensitivity of women. Women could judge it and say, I'm so irritable or I'm so emotional during this time. There's something wrong with that. Well, these tribes didn't think of it that way. They thought this period of special sensitivities women need to be taken care of. And they would do one other thing. The tribal elders would come into the menstrual quarters once a day or so, and they would just sit and listen.
Aw.
Because these women had such special sensitivity that they'd come up with these statements like, Aardvark, the young teenager guy who's 15, seems like such a nice guy in our tribe. We're feeling this guy, and he's getting in trouble emotionally. And we suggest that you put 2 tribal elders on him, and you mentor him, and you take care of him, because he's in a very vulnerable and unstable position. He could do himself or others harm. They can feel this.
It's wild.
Or they could feel such things as what I've heard is, that tribe that lives 3 miles from us that can occasionally can give us trouble? They're percolating. Go send an emissary over there and try and calm them down. Otherwise, there's going to be something adverse. That's how sensitive these women were. Well, the perimenopause is like that.
Oh, yeah.
That's what I wanted to point out. It can be very destabilizing and uncomfortable for the woman herself. But if a man, for example, if she's married to a partner of any kind, woman or man, if you give her space and you listen, she's going to be able to reveal things that are really troubling her. It's not just about hormonal. And if you give most women space, they'll figure it out themselves. Just listen. Just be compassionate. Just be kind. And what you're going to hear, I'll just use the example of a man because if you noticed, I am a man.
Sort of noticeable, yeah.
To be spacious and to listen, I'm going to hear something because of this special sensitivity. Well, I'll just give you an example. This is not an example from my current life, but it is an example from my earlier, when I was younger. I'm upset. And I'm really able to sense it now. You're not 24/7 respectful and kind to me. You sort of put me on a back burner and you prioritize your work and your sports. And I want to be the most important person in your entire life. You're certainly the most important person to me in my entire life. This is sacred. This is holy. We have a chance for love. But when you do behaviors like you're not giving us the time, the sensitivity, the caring, the respect. You're a little gruff with me. Man sitting there listening to this. Because in the perimenopause, if given the chance, she can't hold it back.
Mm.
I mean, I recommend that you don't hold it back regardless, of course. But this is a story for another day and other trusted women advisors and friends. And so don't just judge the perimenopause and its disruptive and destabilizing moods as being wrong. I'm actually recommending the opposite.
Right.
I'm actually recommending that we respect exactly what's going on. And you really take the time to ask yourself, wow, midlife.
Yeah.
What do I want? What do I really want? What do I really, 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 really want? What's going on in my life? It's appropriate time to reassess everything and to communicate to everybody, beginning with yourself, what the truth is for you. Because better living through biochemistry, oh yeah, let's just blast you with antidepressants and sleeping pills. We'll energize you during the day with uppers and we'll put you to sleep at night with downers. Better living through biochemistry. Wrong answer.
Big wrong.
Or we'll be sophisticated about it. We'll just give you the best bioidentical hormone treatment on the planet. That'll mellow you out. No.
Not.
What we do in the menopause method and what we encourage our providers to do is listen. And when a woman's saying, I'm having a rough time, take the time to at least suggest to her, there's going to be a week's delay or 2 weeks delay before your hormones actually arrive. We suggest that you reach out to someone on this planet that you trust and you feel safe with, or find a professional and let them, and someone that you can pour your heart out to. Let's respect the disruption, because these are very, very, very important for your heart, for your life, for your soul, for the rest of your life. It's fun looking at your face, Carolyn. You're so expressive. Yeah.
Well, I just really listen. Anyway, you know.
So you take this time, and we don't try and just get rid of these symptoms of destabilizing and moodiness and sleep disturbance, better living through biochemistry, through the most sophisticated ways of all, through the hormones. No. We ask you to take the time and hunker down on these things that are uncomfortable to you. And if you don't know what they are, get some friends, a woman, hopefully there's someone you have on this planet that you can speak to. And if there's not, no fault, get a professional. This is what these people care about, and one that you trust. So I'm not going to call this time in between the perimenopause, which has been labeled weird or strange or not okay. I will not do that. I'll say we trust everything. And if you're feeling disrupted inside, we want to sit down and hear, or we want you to be heard. Your menopausal provider is not necessarily the proper person to do this for. That's not what we're trained to do. But a woman, if you have a woman friend or a man friend, whoever that you trust, pour your heart out to them. Develop the list and get those things addressed, because they're honorable. You need those things, and they're important for growth. Where does spiritual growth come from in most people?
Right.
Attending to the things that matter to your own heart and soul. So that's all I have to say about the perimenopause, and I'm over time. So I'm going to sign off for today.
No! Okay. Well, guess what? There's always Thursday.
It's Thursday, yes.
And we got through all our questions, and we even got some more. And thank you so much. Have a great couple days, everybody. And you know where to reach me for sure, Sherry, and all that. And so just enjoy. And someone's having a hard time, listen. Listen to them, right? Right, Doctor?
Exactly. All right, everybody. Until Thursday. Bye-bye.